Oops.
Okay, it's recorded again.
Okay. So now the point or the important part of the question that I didn't get was that the patient didn't have a pulse. The heart rate was 34, but the patient didn't have a pulse. So atropine's not going to be given. Epinephrine's going to be given for PEA. So it's very important to know all aspects of your situation and drugs. Now, when would you give albumin? Albumin's a protein. Oncotic pressure is mainly supplied by proteins. So when the oncotic pressure falls, albumin is probably going to be a good choice of fluid because it has protein in it. Does that make sense? Have y'all ever heard of mannitol? In relation to?
Swelling of the brain, like for swelling.
Okay, it's a diuretic, and it's an osmotic diuretic in which it keeps electrolytes but just lets fluid out.
Do we need to know that?
Not just yet, but I thought I would throw it out there.
You said it's a diuretic?
It's an osmotic. It's not like Lasix in which everything leaves, potassium chloride, everything. It keeps the electrolytes in, but the fluid leaves. Now, old school, somebody had mentioned this about an alcohol aerosolized treatment. The old school treatment for pulmonary edema was IPPV with 100% oxygen and a 70% ethanol alcohol treatment. And the alcohol was dispensed by the pharmacy, and you had to go get it when the treatment was needed. And it decreased the surface tension, and allowed for the bubbles to dissipate. I was telling, I think it might have been Morgan, I only used it one time, and we waited too late and had to end up intubating the patient. If we'd have done it sooner, it would have worked. But that's the thing, some of these treatments, you have to go ahead and get them done. You know, you can't wait around.
Wait, so when you say alcohol, you mean like rubbing alcohol?
Not rubbing alcohol, drinking alcohol, like vodka or something like that.
Oh.
Yeah, 70%.
70%.
Yeah, not proof, but a percentage. And I heard stories of older therapists. Anyway, you don't want to know. But yes, April.
I think I do want to know actually.
Albumin is under cardiogenic pulmonary edema, but it's also non-cardiogenic because you have albumin levels that you have to check.
Mhm.
How would you do that? I mean,
Lab.
would you give albumin for?
You would only give albumin if the albumin level is low from the lab results.
Okay, so that would be a non-cardiogenic problem, not cardiogenic problem.
Yes, in that case, yes.
So albumin, it can be both though?
I think it's listed under, well, it is,
It's under cardiogenic up there, but then we talked about it as non-cardiogenic.
Yeah.
So I was kind of confused. Sorry.
yeah, typically the oncotic pressure is going to be related to non-cardiogenic pulmonary edema, not cardiogenic.
So you would give albumin to maybe combat the effects of cardiogenic?
I'm only going to give albumin, or I'm going to suggest albumin if the lab result comes back and the albumin level's low.
Whatever the issue is. Only
Right,
if
that's basically what it comes down to, because look back at the causes on page 295. So if I have a metal poisoning, I'm going to try to get rid of the metal that the patient has inhaled from whatever job that they're on or whatever. How is that going to be done? I don't know. It's going to be specific to what they've inhaled. There's some probably oxygen's going to help remove some stuff. If they have an encephalitis, I'm going to find out what virus is causing the brain inflammation, and then do the antiviral or antimicrobial for that particular thing. Those are what's going to really stop the fluid from moving, is getting rid of the problem. So if the heart is the problem, we can't get rid of the heart. We have to get rid of the ischemia. We have to get rid of the arrhythmia. We have to get blood flow back to the coronary arteries. So we have to get the valve repaired so that it closes all the way. And so when it's the heart, there's some specific things that have to typically be repaired. If it is a non-cardiogenic problem, then we have to find out what got inhaled, what went into the lungs to cause the increased capillary permeability. Does that make sense? Once the fluid though has started moving, now we've got this problem with this increased fluid in the lungs, and ultimately it's going to increase the work on the lungs and the heart, ultimately. So we try to fix the problem as soon as possible, and fixing the problem is going to involve the history. What have you been doing? What's been going on, to try to find out. And when we start doing our diagnostic test, when I get an x-ray and I see that the heart's a normal size, now I'm not thinking about the heart anymore. I'm looking at some other causes because the heart's okay. And it was not uncommon when I was working to put in a Swan-Ganz catheter as soon as the patient come in, and then we would get a pulmonary capillary wedge pressure and know if it was the heart or not. Because the wedge pressure elevated would tell us this is a cardiogenic pulmonary edema.
How do you get the wedge pressure?
There's a catheter that goes from the superior vena cava to the right atrium through the tricuspid valve to the right ventricle, and it goes up through the pulmonic valve and sits in a branch of the pulmonary artery. And so when the balloon at the end of that catheter is inflated, it blocks off blood flow so that the pressure that's in the capillary can be measured. And that's not done as much anymore unless they are truly with a heart problem from, typically you don't see a pulmonary artery catheter unless they have open heart surgery, and they'll come back with a Swan-Ganz catheter only long enough to make sure the heart's doing okay. Now, another thing that may have to be done if they go into cardiogenic shock from cardiogenic pulmonary edema is an intra-aortic balloon pump. Have y'all heard of one of those? And that's a catheter that's got a balloon in it, and it's going to be fed up through the ascending aorta, and then it's going to sit above the renal artery and below the subclavian artery, and when the left ventricle has ejected blood, then it's going to inflate, and that is going to help push blood back to the coronary arteries to increase oxygenation. And just before systole, the balloon is going to deflate, and when the balloon in that big area deflates, it almost acts as a suction. So it's going to help the left ventricle. It's say that I'm the catheter and I'm the balloon, and I deflate, the blood that's coming from the left ventricle is going to want to move to that area easier because of the drop in pressure. And so it's only used in really drastic situations, but that's another thing that might have to be done.
So is that permanent or no?
It's not, no. And we'll learn about that in the fall semester. Why would you use rotating tourniquets or phlebotomy in pulmonary edema? It removes fluid. So instead of the heart having to push the fluid out, you remove it. The vessels can't hold anymore, so it's rarely done, but that is something that may be done in extreme situations. I've seen phlebotomy a couple of times, but not the rotating tourniquets. Okay. So again, I realize that we had, already talked about all of that stuff, but pulmonary edema is something that you're going to come in contact with. You're going to need to notice it. You're going to need to make suggestions for treatment. So the other problem that can happen in the vasculature is an embolism. Now, what's the difference between a thrombus and an embolism?